again, documents. I've selected that particular, but I am unable about neuropathy in my practically. My option and my lecture will be a practical presentation by a physician. My endeavors will be as a physician perspective to peripheral neuropathy. Okay, so what is peripheral neuropathy? How it has been defined? It's a pain arising as a direct consequence of lesion or disease affecting the somatosensory system of the body, and that's the definition by International Association of Study of Pain. As you know, any of diabetic patients, the most common presentation, if you poke that patient, if you try to ask that patient properly, then is the most common presentation is peripheral neuropathy. Almost 60% of the diabetic patients suffer from these kind of neuropathic excruciating pain, which are somehow very, very worrisome and decreasing the quality of life of that patient. Now, how can be presentation? Clinical manifestation may be pain, burning, numbness, paresthesia, loss of sensation, defined as presence of symptoms and signs of peripheral neuropathy, excluding by different causes. Diabetic peripheral neuropathy, how common? It's very common. From almost 60 to 70% have foot ulceration, foot amputation, gastroparesis, impaired quality of life. Pathogenesis, we all know that pathogenesis is long-term diabetes, long continued poor control of diabetes. And hyperglycemia is the mainstay of the disease, which causes oxidative stress and activation of protein kinase C enzyme. And this protein kinase C enzyme causes hyperglycemia. It causes diabetes and glycation end products. With phosphokinase C is a storm which causes ENOs, ET1, TGF-beta, PI1, NFK-beta, all these cytochrome storms occurs. And apart from, as a conclusion, as a cascade of that, we get a blood flow abnormality, vascular occlusion, and pro-inflammatory gene expression. So these are the busy slides I can show. I'm not able to tell you properly because I'm not able to share because of my small knowledge of sharing my slides, but I can very well make you understand what I have written and what I'm going to show in my slides, small slides. It's a busy slide showing you polyol pathway. There is so many things which occurs as a radical oxide pathway, decrease in glutathione, susceptibility of oxidative stress, increase sorbitol accumulation, increase in osmotic pressure, and causing nerve damage. So these occurs, and these are the advanced advanced glycation end product cascade, which causes modification of intracellular proteins, modification of extracellular matrix, and this causes protein cytokines, and there is permanent nerve damage. So augmentation of hexosystem pathway activity, augmentation of unifying mechanism, these all complex mechanism which goes inside the body causes permanently nerve damage. Apparently, these nerve damage can be tackled if we know the physiology and pathophysiology of the disease, and we can burn this, we can make the patient properly happy if we know how disease progresses. So PKC pathway and oxidative stress is the main disease behind, main pathophysiology behind this. Hyperglycemia, diacylglycerol, PKC activation, activation of pro-inflammatory markers, free radical production, and these all leads to nerve damage. Domains of neuropathic pain: the quality of life is hampered, physical functioning, ability to perform activity in daily work of recreation, psychological morbidity, depression, anxiety, anger, sleep disturbance, and loss of self-esteem, social consequences, negativity of complication in marital family, psychosocial need is decreased, socioeconomic consequences because the disease are cripplesome, they take many pennies from your pocket of health, and that's why these disease is cripplesome and doesn't decreases the quality of life. Presentation pain may be hyperalgesia, stabbing pain, pins and needles, electric shock like sensation, numb sensation, throbbing sensation, shooting sensation. This is the pain cascade, how pain goes, how pain is intercepted, how transducted, how transmitted, how modulated, and how perceived in sensory cortex. We have a pathway. Nociceptors get a stimuli from the peripheral sensitive system. They give the stimuli to the peripheral nerve, and through there are three variety of neurons. One is first, two, and three. First neurons catches your sensations on nociception to the dorsal horn, then dorsal horn to the thalamus, and thalamus to the sensory cortex. And there is one descending pathway, which is an inhibitory pathway, which takes care of your pain by giving serotonin and your adrenaline, norepinephrine, which is a inhibitory pathway which takes care of your pain. So excitatory neurotransmitters are glutamate and substance P. I don't want to go in exact molecular physiology of these, because you don't, if you remember also these chemical names, these are not going to help you a lot. What I want to show you that inhibitory neurotransmitter is a mechanism where thalamus and our descending top pathway is inhibited by endogenous analgesia, and this is the mechanism which takes care inherently about our pain. What is pathophysiology of neuropathic pain? It's a peripheral sensitization and central sensitization. I have given and I have shared slides to the team. If they can also share that slides from central core, then it will be very easily visible to all of you. Vikas, can you do that? I have shared the slides to you. Can it be done from your side also?
Excuse me, sir.
Yeah.
Hello. Sir,
Hello.
please tap on share option and then on the
I
screen.
tabbed also, but I'm not getting. Whether you people have lost interest in my
Are
slides,
you
I don't know.
getting,
Yeah.
sir, are you getting any option below document
Share,
screen?
share, 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 share. Yeah, I got share.
After tapping on share, you'll be getting an option of screen sharing.
I'm getting photo, document, box, Dropbox, photo, document. What I want to share, I want to share the document. So I will keep in document. In documents, I have these slides. These slides are coming PPT presentation. I have done this presentations, but again it's not
No,
coming. I've
sir,
shared also.
you have to tap on screen option. You will get the screen option just down to the bookmark.
Sorry for disturb, sir. Please continue. All picture, all voice is audible,
Okay.
and please continue, sir.
Okay, let's continue. Otherwise, you can share also. You have shared. I have shared the slides to you also. You can't share that, Vikas.
Yes, sir. Hello. Yes, sir.
You
Please
can.
continue.
You also can share. You also can share.
Yes, sir.
Okay, chalo,
After the completion, we share.
Okay. So pathophysiology of neuropathic pain is a peripheral sensitization, central sensitization. There is two mechanisms by these two we use to tackle these kind of pains. Okay. Peripheral sensitization, when there is a damaged neuron, nerve lesion, compression, or release of nerve growth factor occurs in that place. An increased expression of sodium channels on damaged nerve as well as on the uninjured nerve. This causes increased pain, impulse, or transmission. If you keep on damaging your nerves, see in amputation, in phantom limbs, in these kind of, or repeated injury to your nerves or any part of your body, there is accumulation of nerve growth factor, which causes increased expression of sodium channels, and the channels get open. There is a depolarization of that membrane, and there is excessive cry of that membrane and nerve, which causes these kind of repetitive impulse, and these nerve get permanently damaged, and there is permanent cry of these nerve causes sensation to our sensory cortex, and our pain axis get activated. What are psychological aspect of neuropathic pain? Psychological aspect of neuropathic pain is patient get depressed. Psychological factors amplify the perception of pain and associated disability. Up to 60% of chronic neuropathic pain sufferers are experienced from depression. Patients get chronic pain frequently report a wide range of limitation in social and professional roles. Co-prevalence rate of depression with these neuropathic pain is around 30%. And because of this neuropathic pain, the patient can have a very poor quality of life. Pain does cause sleep disturbances. Pain is prevalent in sleep sufferers. 50% of individuals with chronic pain have sleep difficulties and experience in problem in working experiences. Depression, increased pain, anxiety, chronic. This is a chronic pain cycle. How to diagnose? These are peripheral tools. How to diagnose this pain? Pain case history, physical examination, biothesiometer, tuning fork, and other things you can use. A sensory system tool, motor system tool, sympathetic system, localization of pain. You can do. Pain treatment continuum. Continuum not related to efficacy, most or either to least invasive to most invasive methods. Psychosocial support, physical approaches, topical medications, systemic medications, interventional techniques. My topic as a physician perspective is not totally as a physical approach and topical medication. I will not go to intervention approach because that's not a subject of my topic, and I just not scope as a physician to go get that. Neuropathic pain management, treat the underlying condition. If patient is symptomatic, give treatment, anticonvulsant, antidepressant, opioid, topical. Drugs affecting pathophysiology, you need to modify your pain pathway by methylcobalamin, folic acid, pyridoxine, benfotiamine, alpha-lipoic acid. And vital, because it's a diabetic neuropathy, you need to tackle diabetes properly, because diabetes, if not tackled properly with a guidance of diabetologist or endocrinologist or a good physician nearby to you, you're not able. Management of neuropathic pain, palliative therapy, guideline recommendations. First line treatment is alpha-2 gamma ligands, pregabalin, gabapentin, TCADs like norepinephrine, amitriptyline, serotonin, noradrenaline, reuptake inhibitors, SNRIs like duloxetine, venlafaxine. And second line treatment are tramadolol, capsaicin, lidocaine. Third line treatment is strong opioids like morphine and fentanyl. Pharmacological agents affect pain differently. They handle pain through descending modulation and central sensitization mechanism and peripheral sensitization. So you need to tackle both peripheral sensitization and central sensitization, because if you're not going to tackle both, you're not going to able to handle this neuropathic pain properly. Assessment of treatment response. If your pain get reduced by 80%, then you need to say your patient that 20% part and parcel of diabetes neuropathy, we can't get a proper fully cure neuropathy, but we can have a good reduction. And 80% reduction in pain is almost a sign of almost remission of the symptom. Pain 50 to 80% is partially controlled. If pain is reduced by less than 50%, then it's a continual pain, it's an uncontrolled pain. Uncontrolled neuropathic pain can unaddress, and with monotherapy, it's almost we can't address with monotherapy. Need to go for a pharmacopoeia of different drugs. 45% of pain patients need to more drugs adequately. Uncontrolled neuropathic pains reasons are either they are incomplete efficacy of drugs we have used, or they're dose limiting due to the side effects, or titration of therapy due to we have titrated monotherapy. केवल एक ही दवा को हमने डोज बढ़ाते रहे और दूसरी दवाओं को हमने यूज नहीं किया जुडिशियसली, तो विल नॉट गेट द रिजल्ट. डू नॉट एड्रेस द साइकोलॉजिकल कंप्रोच. इफ हमने अगर पेशेंट की पेन से रिलेटेड साइकोलॉजी को अटेंड नहीं किया, साइकोलॉजी को ट्रीट नहीं किया, देन वी विल नॉट गेट rid of that. So integrative approach, we need an integrative approach. Drugs acting at different sites, we need to enhance pain relief, we need to lower the dose of one drug, we don't get in the side effects of one drug, and that can have a better quality. So all guidelines, ISAP, NIC, FAV, Canadian Pain, and other Mayo Clinic proceedings, they say that you have to go with a management approach, a total management approach. And pain management approach is all of the things properly rather than treating one. Neuropathic pain management, pharmacology therapy, non-pharmacologic therapy, proper physiotherapy, neurotropic therapy, pain palliative management therapy. Palliative therapy is analgesic agents for addressing the neuropathic pain and associated comorbidities like anxiety, depression. And neurotropic pain, we have to give multivitamin, B6, alpha-lipoic. These are neurotropic agents. Neuropain modulators for managing painful neuropathy. Pregabalin. This is the mainstay of the therapy basket. We used to give pregabalin, totally rely on this drug because these are tested time for a long time, and we are having this drug in our armamentarium of treatment. A large number of clinical studies have shown effectiveness of pregabalin in managing neuropathy. Pregabalin suppresses ectopic neuronal impulses and hence is efficacious in patients with lumbar and cervical radiculopathy. What it does, it suppresses ectopic neuronal impulses which are repeatedly coming from damaged neurons. Pregabalin shows significantly great improvements in pain-related interference with sleep. Because if your sleep is disturbed, every time you get up with pain and your sleep is disturbed, your psychosocial quality of life has been disturbed, your sugar will get haywire, because if your sleep is disturbing your pain, then you are not going to get proper quality of life will be hampered totally. So, am I audible to all of you?
Yes, sir, you are audible.
Yeah. In patients with low back pain, pregabalin improve pain function and overall status. This is the mode of action of pregabalin. If in a patient where pregabalin is used and a patient without pregabalin, you see there is opening of calcium channel. There are a lot of coming up of the neurotransmitters, and they are going up in the depolarizing the nerve membrane, and they are causing excessive pain. So the repetitive impulses is coming. Another is now nortriptyline, a widely used drug for treating neuropathic pain. Nortriptyline is a tricyclic antidepressant commonly used for neuropathic pain around the world. Nortriptyline is preferred as to amitriptyline because it has lower incidence of associated adverse effect, which can increase patient compliance. So nortriptyline is mechanism of action. It acts on the descending inhibitory pathway. It inhibits uptake of serotonin and norepinephrine in the descending pathway, and it potentiates the action of the inhibitory pain pathway. So by pregabalin and by adding nortriptyline, we create a whole basket where we can handle both pregabalin, glutamate substance, ascending pain pathway, nortriptyline, serotonin, norepinephrine with descending nerve pathway. So complementary mechanism of action. Pregabalin acts as an ascending pain pathway, and nortriptyline acts on the descending pathway. So tackles psychological condition. Pregabalin reduces anxiety, and nortriptyline reduces the depression. So side effect of the both drugs, which can be increased if you go in one axis and increase the dose of one drug only, then you'll be having a side effect profile of that patient. So pregabalin versus gabapentin. Earlier we have gabapentin, now we have pregabalin, and if you compare with these two drugs, then pregabalin stands better because it's 6 times more than receptor binding. It's more than 6 times in pregabalin. Analgesic effect is 2 to 4 times more potent. Viability is almost 90% of all doses are viable. If you compare with variable doses of gabapentin, then you need to increase the dose to so much amount. So gabapentin, you need for effective need, you need to go for a very high dose. Dose response is more predictable with pregabalin rather than gabapentin. Tolerability profile, yes, there is always a tolerability issues with gabapentin, pregabalin. Always you need to say your patient that, see, if you suffer from dizziness, giddiness, or any kind of sleepiness, you need to decrease the dose. Somnolence, dizziness, 8%. Doses clinically used is 50 to 600 milligram per day, and BID or TID can be used. Significantly, pain relief comes in 1 week with pregabalin. Initiate with one tablet, take once orally, then can be BD and try it preferably at bedtime because sometimes patients develop dizziness. So clinical evidence. There are some studies with VAS score. There is 54% reduction in anxiety score, 39% reduction in VAS score. Depression score decreases by around 35%. So clinical evidence are also with the studies with pregabalin. They have shown that VAS score, anxiety score, depression score, sleep disorder score, all has been tackled good by this. So combined alpha-2 ligand with beta ligand pregabalin with nortriptyline TCAD provides a better pain relief than the single drug therapy. Pregabalin improves back as well as leg pain, so it's very helpful in radiculopathies. If you talk about lumbar radiculopathy, then pain reduction profile and significant quality of life improvement has been seen with pregabalin group around 56.1% if you compare with a non-pregabalin group. So while I'll just brush up my whole presentation, although I know that this was not a very good readable option given by me, but I have gone through all kind of aspects of neuropathy. And while there are many treatment options and combinations for neuropathic pain, focus of this meeting was around three important criteria: efficacy, safety, and favorable tolerability profile of the drugs which are available. So my point of take to you people as a physician, because I am a physician, I can talk, or your physician, I can not talk about the intervention part. Intervention part of neuro blockage and other things can be taken by a neurospinal surgeon. So psychological physical approaches to pain management include relaxation therapy and your physical exercise programs given by the physiotherapists, the trained physiotherapists. Topical medications consist of lidocaine patch, capsaicin, and variety of custom compound topical agents. Oral medications, I already discussed with you, TCADs and anticonvulsants like gabapentin and mexiletine and baclofen has been used also. Injectable medications are nerve blocks and local infiltrations that are usually administered with local anesthetic and steroids. And neurospinal intervention is beyond scope of this talk, and techniques that require specialist for spinal cord stimulation, spinal analgesia, brain stimulation, and various neurosurgical blocks, the dorsal entry of June lesions. So summary and the last slide of my topic is pregabalin and norepinephrine is a cheap and first-line therapy option, easily available to our patients, easily tolerable to our patients. Combination of pregabalin and norepinephrine acts on both pain pathways and provide enhanced pain relief. The combination successfully tackles the psychological component with pain, that is anxiety, depression, sleep deprivation. Uncontrolled neuropathic pain, which can decrease the quality of life, hamper the patients to come to clinic properly, and patients get irritated most of the times, this dull aching pain and sometimes excruciating pain. Sometimes they are leading to myopathy and amyotrophy also. So pregabalin and norepinephrine combination improves overall quality of life and thus provides therapeutic outcome. This is my last slides, and I thank you to you.
Thank you so much, sir, for your time.
हो रहा है मैम, अब तो स्टार्ट हो रहा है मैम.
We are already late because of some hiccups from